for about 22 years. Background is EMS. Started out as an EMT Army medic back in '81, so I know what a pager is. This started, I think, a bit over a year ago to try to get geared up and trained up in order to respond to the COVID issue. And I'm real happy to be able tonight to talk about abdominal pain, something much more I find much more academically appropriate. And the way we're set up, Michaela's going to be running my slides, and as folks have questions, jump in. This is I find with my students, I'm a prof with med school. The quicker they jump in, the more meaningful the question becomes, and frankly, if you're thinking me asking a question, half the other people probably are too. So why don't we go ahead and get rolling there? So our basis of our course is the O'Keefe's edition of the emergency care. I'm using some of their chapter findings to go through this. So we'll go ahead and move on to the next slides. So first we got to talk about is abdominal anatomy and physiology. We all know that the abdomen contains a lot of organs, multiple different body systems. This can really cause confusion both from an EMS side and from a physician side as to narrowing down the cause of that abdominal emergency. Thorough patient assessment is key. You don't need to have a specific diagnosis, but what history and what you can find on the scene or at the house is very, very important. Michaela? So basically, the abdomen defines that region between the diaphragm and the pelvis. And when you think about it, when you breathe in, breathe out, the top of the abdomen extends into the chest and goes down into the pelvis. Basically, we usually think of the abdomen as, quote, full of guts. Well, it is. It's got digestive function. In women, it's in the pelvis, reproductive, endocrine, when we think about things like pancreas and insulin production, a lot of regulatory functions. Okay, Michaela. So first, let's look at these solid organs. In the right upper quadrant, I'm sure all aware of the quadrant system. You have the liver, and then hanging right below that is the gallbladder. So that is not a solid organ. So when you're approached to the patient that say that you're at the house or wherever is having pain, they say, yeah, I've had right upper quadrant pain. If you were to verbalize that back to the receiving facility, we'd start thinking pretty long and hard while we're waiting to get the tools and the toys lined up to assess that. There's also a pancreas that kind of underlays that, more in the back and a lot higher than a lot of people think are your kidneys. Looking over here at the right, hollow organs such as your stomach, the gallbladder, the duodenum, the intestines, and the bladder. Go ahead, Michaela. So we define this with umbilicus as top dead center, that's the bullseye. And you run a line up to the xiphoid notch and then down to the symphysis pubis, and then you got your left and right, and your up and down is a horizontal line through the umbilicus. Now, one of the things to think about is peritoneal or extraperitoneal space. So peritoneal would be within the parietal pleura, and extraperitoneal are those things that are outside. So things like the kidney being outside of in the extraperitoneal or in the retroperitoneal cavity, pretty well protected when you think about as far as or as far as blunt trauma. There's a lot of stuff in front of it. Obviously, penetrating trauma such as gunshot wounds, not so much. But in this sagittal view, you can see kind of how the pancreas, the duodenum are in roughly the same place, but one's inside the peritoneum and others are out. Note too where that abdominal aorta is. It's right up against the back. So if you go to a scene or go to a house or whatever, and they're complaining of midline abdominal pain that radiates to the back, you need to be thinking about an aneurysm. And moving on, we can see stuff that's within the peritoneal cavity: spleen, liver, gallbladder, stomach. Go ahead. So visceral pain basically originates from the organs within the abdomen. They don't have a lot of nerve endings. And so a lot of times that sort of pain is just kind of dull. The history taking is it's not pinpoint. It's just more achy, and it's more in a area rather than a pinpoint area. Go ahead. Versus pinpoint pain such as go back, yeah, say for the appendix. So visceral pain tends to be colicky, and things like people that are constipated have a lot of abdominal pain due to the distension, and also can have persistent or constant pain. That's generally going to be more from solid organs, not so much for the large or small bowel. Go ahead. Parietal pain or peritonitis originates from that covering of the peritoneum. Uh, Very well, a lot of innervation, a lot of nerves ending up in there, has various efficient sensation of pain, frequently described as sharp, and it's very much localized. So peritonitis, one of the old things before we had CT scanners, not only would we do an exam, a good abdominal exam, especially if we were suspecting appendicitis, we just have, usually the kid was 12 to 15, have them jump up and down, and basically if they scream and point at the right lower quadrant, that's what it is. Next. So there's also some pain is more of a tearing pain, and this is where one of the things that used to be found mainly on autopsy before really good imaging is a tearing pain that radiates to the back. Um, Go forward a slide for the aorta. Um, and basically, that tearing pain is the big arteries have multiple layers of construction, and as you tear through the layer, um, that results in that type of pain. Appendicitis, as we discussed before, can cause minimal to moderate pain. It can be focal. Generally, it's focal, right lower quadrant. It can wax and wane for a few days, and then it gets persistent. And then when they actually rupture, uh, patients will report they have a sudden severe increase in pain, and this is releasing basically small bowel contents into the peritoneum, which causes real severe peritonitis, very much inflamed. Peritonitis is described as the inflammation irritation. Usually it's foreign material, as in feces. Very sensitive, especially to acidic substances, and basically can cause some involuntary contraction of the anterior, especially abdominal muscles. That's where you get that rigidity. So if you go up to examine somebody that has peritonitis, first of all, they may not even let you touch their abdomen. And then if they do allow you to touch their abdomen, you say, relax, 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 and they just will not relax to get a good belly exam. Well, it's because it's involuntary. That muscle is contracted. Next slide. The other type of pain that some of us probably have had is cholecystitis, or bad gallbag. Basically, you have the gallbladder, and the way to get rid of the bile. Remember, bile is how we break down fats, and you get a rock in there, and basically the gallbladder bag stretches, and that gives you significant right upper quadrant pain. And basically, before the HIDA scan, when you're trying to figure this out, you just ask if it was questionable. What happens when you eat a cheeseburger and fries? And basically, if they say it gets really bad, that's almost diagnostic. Obviously, now we confirm it with an ultrasound or a HIDA scan. The other thing to think about too with gallbladders is sometimes folks will come in with right scapular pain. I've seen that quite a bit. And one of the things to think about too is anytime you have back pain associated with abdominal pain, especially in women, think cardiac. I'm kind of getting off the slides here, but that's okay. At one point in time, it was published that less than 50% of women have classic angina with shortness of breath, diaphoresis. And one of the most common complaints for women having cardiac disease is uh, nausea and back pain. So always kind of keep that on your differential. Go ahead. Pancreatitis comes in a couple forms. Most commonly would be acute versus chronic. Some people with chronic alcohol abuse basically have chronically elevated pancreatic enzymes. They have pain that comes and goes. Basically, pancreatic pain it can be in that same realm as gallbladder pain. Sometimes the symptoms are more epigastric, but a lot of times they are referred to the back. But generally speaking, the cases I've seen over the years of pancreatitis, they have a lot of pain anteriorly, and then they sort of explain as you're doing your history that it also radiates to the back. Tough one to differentiate without imaging uh, with acute aortic dissection or an aneurysm. So GI bleed may or may not present itself as an emergency until the person's bled out enough that they're short of breath. So back in the day before people were getting regular colonoscopies, colon cancer would present with somebody short of breath, not feeling good, and they would have a really low hemoglobin, and you would check their stool for blood, and they would be positive. So any hemorrhage within the lumen of the GI tract, by definition, is a GI bleed. There can be AVMs or arterial venous malformations in the small bowel. Probably the most common cause that's medically very important is the GI bleed, either from a gastric ulcer, which tends to be very um, not so much painful, just a lot of reflux, um, and also that comes from colon cancer. Other causes that are probably more common, but not as significant medically, include hemorrhoids. Now, a gastric ulcer, as long as it's not perforated, is a lot of folks just come in and say they've got a lot of problems with reflux. If that goes on long enough where the gastric ulcer actually opens up into the peritoneum, it is really a surgical emergency. Severe pain, peritonitis. Obviously, you can't have gastric acid leaking throughout your peritoneum and survive very long. So, signs and symptoms of GI bleed, probably the number one is black or tarry stools. Frank blood from the rectum tends to be more hemorrhoidal. If they're vomiting, this is an often quoted term, coffee ground emesis. That's almost always a gastric ulcer. And usually vomiting of frank blood is an esophageal ulcer. And the whole gamut as far as pain may not even be present to extreme pain. So a hernia, probably not a lot of EMS calls for hernias, but basically we think of an inguinal hernia. You can have an umbilical hernia, any place where there's an opening in the abdominal musculature that allows intestine to protrude up against the skin. Some of these are not even significantly problematic. I have a lady that's pushing 100 who I've talked to her for almost 20 years. She's got a grapefruit size abdominal hernia, and she's been right for 20 years, and I've been wrong because she says it doesn't cause her problems why go through the surgery. So it's not always an emergent problem. Some of these folks live with them for years. The big thing that you have to be concerned about, though, if you do find a hernia. So if, let's say, a piece of small bowel came out through an opening about that big, and you have this much bowel, if it twists, it strangulates. In other words, it cuts off the blood flow to that portion of bowel that's out in the hernia. And that's significant because the bowel that cannot get a blood supply will invariably die, and that will lead to peritonitis, sepsis, and subsequent death. So basically, a strangulated hernia falls into that emergent abdomen sort of picture. Now, renal colic, when I teach medical students, is the worst pain ever. I've had a lot of women that have had very large children who tell me the pain of delivery is nothing compared to the pain of the stone. So basically, the person, when you come in, will be doing what I call the kidney stone dance. There's no place you can get feeling better. There's no position that you can get feeling better. And basically, you're trying to put a rock through a tube with the stone being formed up in the kidney and trying to travel down the ureter into the bladder. And as that builds pressure up, the pain is intense. Additionally, if it's left long enough, it can cause significant kidney problems. So the signs and symptoms are severe cramping. Sometimes they have referred pain to the groin. I've had people with referred pain to the hip. And the pain, it can be so severe that some folks actually vomit. Not sure if it's a direct relationship to the stone itself or to the amount of pain. Go ahead. This is what I brought up before, and this is something as EMS providers we really need to be thinking about. You know, the old story is that we think about worst case scenario first, and when we find out it's not, then that's good. But pain from a heart attack may be felt as abdominal discomfort. Had once again, women tend not to have the classic signs and symptoms of heart attack. If you had somebody that had epigastric pain and indigestion, I don't think anybody would call you for putting them on oxygen and think about cardiac as on your problem list or your rule out list. So always consider the possibility of ischemic event as a cause of abdominal symptoms, especially if they have epigastric pain and they feel short of breath, or if they're diaphoretic. Then that really needs to move higher up that list as far as concern for cardiac conditions. So let's talk about assessment and care of abdominal pain. So we've talked about there's a lot of different causes. And frankly, the high resolution CT and the use of ultrasound, once you get the patient within a facility, have really made sorting these issues out fairly straightforward. Once again, the role of the EMT is not to diagnose, but at least think about these problems. Once again, if you think there's any possibility it could be cardiac, put oxygen on them. Not sure if I would recommend you have them chew aspirin, because if it's a gastric ulcer or something, that certainly could lead to a more negative outcome. So what I would say is the physician waiting in the ER for the rig to arrive is perform a very thorough secondary assessment. In other words, is it pain left upper quadrant only, or does it radiate? Is it right upper quadrant, made worse with a cheeseburger? That sort of thing. And one thing to always keep your eyes on is try to identify any symptom or sign of shock. because then you have to think about significant blood loss. You can store a lot of blood in the abdomen pelvis, and that can lead to exsanguinating death. So go ahead. So let's go back through. Some people would say this is kind of boring primary assessment. This is what I'm going through my head when I'm trying to figure out what's going on in the ER. First is that general impression. Does that patient look really sick, or do they not look sick? And after you've been on the rigs for a while, you'll know what I mean. I'm assuming most of you have been on for quite a while. Always assess airway, breathing, circulation. And then once you determine that those are at least intact or somewhat stable, sometimes somewhat stable is as good as you're going to get it, then ask just a few key questions to determine level of consciousness. And things like, when was your last meal? What day is it? That sort of thing will give you a good general sense if the brain is being um, oxygenated well. Always consider O2 in somebody that's got abdominal pain. If they're hypoxic, just go ahead and give it to them. So here's the questions that are real important for the person waiting to see the patient in the ER. Okay, when did the pain begin? Has it been off and on for the last 6 months? Has it been off and on for the last 6 hours? And by the way, what were you doing? And if they say something to the effect of, well, I just had lunch, once again, we go back to narrowing down what the possible cause is. The next question is there anything that makes it feel better or worse? And one of the things that I've seen with people with hiatal hernias is they tell me when they stretch their back out, it relieves the pressure. So find out, does movement make it worse? Is there a certain position? And then ask them to describe the sensation in the abdomen. Is it sharp, local? Is it diffuse? Or am I sick and I hurt all over? That's generally a tougher workup. Go ahead. So the other thing you can do is have the patient say, where does it start? And does it go anywhere? Those are all key history things. And get an idea on a pain scale, kind of where you're at, with 1 being little or no pain to 10 being basically a kidney stone. The other questions to ask is this pain continuous, intermittent, and if you've had it long term, what has changed about its nature, severity, etc. Always do past medical history. The ample mnemonic works pretty good. You know, it's nice to know in the minute somebody comes in, by the way, this person has an allergy to penicillin or whatever the allergy it is. It's always nice to know what medications they're taking. And pertinent past history, if they've already had their gallbladder, their appendix out, you can pretty much take that off the workup. Last oral intake is absolutely imperative. So when I go to call and talk with my surgical colleagues, I'll report a 60-year-old male or female last oral intake was. And then the E part of the events leading to the emergency. In other words, did the abdominal pain start after getting elbowed in or about the spleen? Did the pain start when you were in a car wreck, or did the pain just start randomly in the middle of the night? They all have different etiologies and different workups. Now, I do a lot of geriatrics, and this is very important. And if you're in EMS in rural South Dakota, geriatrics is a huge part of what you're doing. And one of the things to remember is they have, just as the aging process, people, especially once you get over about 75, have a decreased ability to perceive pain. Now, it could be perception, it could be overlying with all the medications they take. They tend to have more serious causes of abdominal pain, with abdominal aortic aneurysm being the most life threatening that comes to mind. They also can, just like in when you have a coronary artery shut down, leading to a myocardial infarct, people in the geriatric subgroup actually can have what's called mesenteric artery ischemia. There's an artery that goes to the bowel and provides blood to the small bowel, large bowel. It goes different places. And if they get cholesterol blockage of it, it's almost like a form of abdominal angina. And once again, if that totally would block off, then you have a section of bowel that doesn't get blood. It's going to get necrotic and die and lead to sepsis. And the other thing about geriatric population is the whole workup is complicated by medications. The number one being all the different novel anticoagulants, Plavix, Coumadin, all the blood thinners really make for requiring a more sophisticated approach to the evaluation and treatment. So now actually pull the shirt up or open it up and take a look. So is the abdomen distended? Is it discolored? Does it have a bunch of ecchymosis? Does it have a grapefruit-sized lesion protruding out through the umbilicus, in which case it's a hernia? And then when you go to palpate, start really light with the fingertips and start in the non-painful areas. And if you're starting to, as you get to the more painful area where the patient is involuntarily, it's called guarding, not allowing you to exam, the abdomen is rigid, you can pretty much say that this is going to be a surgical case. Maybe not need to go to surgery right away, but needs to be fully evaluated for a surgical problem. So once again, rigidity, bad sign; guarding, bad sign; pain. Everybody seems to have a different pain tolerance. You'll get that figured out with palpation. So the vital signs, once again, we're looking for potential exsanguinating bleeding, sepsis, that sort of thing. So if the pulse is up, we can think either A, they're anemic; B, they're in a lot of pain; or C, they might be septic. Respirations, document if they're breathing hard and heavy, get them on some oxygen. Check their blood pressure. The other thing is skin color, temp, and condition. I mean, if they're kind of blue and dusky, uh, definitely don't trust your pulse oximetry. Get them on oxygen. And while I'm thinking about it, let's talk about pulse oximetry. In general, when it works really well. But uh, always remain vigilant to the fact that, especially around ice houses and people's garages, people that are working using open flame or propane heat and that sort of thing, they can be significantly hypoxic with carbon monoxide poisoning and have a normal pulse oximetry. All a pulse oximeter does is tell you if the hemoglobin is occupied. And probably the most sensitive thing to perfusion status is mental status. I mean, if they're oriented times 3, good. If they're altered, bad. So general abdominal distress, some could be cardiac, some could be diabetic. They tend to not empty, people with diabetes tend not to empty their GI tract very fast. It could be food poisoning, or it could be gastroenteritis. Right now in this part of Spink County, I, I have not really tested for it, but I think we probably have some norovirus because it's really going through the community, characterized by nausea, vomiting, and explosive diarrhea. On those folks, when you get called, it's probably going to be as a consequence of them being dehydrated. The other thing, if you got somebody that's vomiting, get a good airway exam because the risk of aspiration, especially if they're over 60, any alcohol on board, that sort of thing, really increases the risk of aspiration pneumonia. Try to keep a calm voice, keep people calm down, reduce anxiety, and never give the patient anything by mouth. Be prepared to suction. Oxygen saturation, as long as it's in the 90s, that's pretty well where we want it. That data always seems to change every 10 years. I think 94 is a reasonable eval. Um, Always, especially if they're vomiting, get them over on the left side, so kind of to help that airway. And transport to appropriate facility, especially if you have somebody that is hypoxic, febrile, and looks like they have peritonitis. Don't stay in place, scoop and run. So let's think about this 89-year-old female, history of diabetes, hypertension, gallstones, nausea and dizzy all over, about 20 minutes after eating. So, what are the concerns with this patient? Well, is dizzy a manifestation of a stroke? Is it a manifestation of a cardiac problem? Are they hypoglycemic? I think most rigs have a glucometer. That's the first, after putting oxygen on her and doing an initial assessment, I'd go ahead and, while you're doing that, get a glucometer. The main thing is you may not know in the field, but your treatment should include oxygen, protect the airway, and if she acts like she's starting to get nauseated, better have your Laerdal ready to go for suction. I'm not sure, does Laerdal still make the suction devices? I'm a little bit old, so. So basically, to review what we went through over the last approximately 30 minutes, all abdominal pain or distress should be treated as serious and require transport. Remember, as an EMT, responsibility is to assess and report your findings. Don't get hung up with trying to figure out what the exact diagnosis is. Got a lot more resources in the ED than you do in the back of your rig. Once again, especially if there's other manifestations like elevated temp, hypoxia, that sort of thing, definitely a load and go situation. And being able to come in and give a good, quick, thorough, focused, went to such and such's house. They've had right upper quadrant pain for the last 3 to 4 hours, now nauseated, vomiting. Uh, Wife said, or husband said, whichever family member said, has a history of diabetes, hypertension. On physical exam, cardiac sounds are good, lungs clear, no bowel sounds present, and vitals are whatever, hypotensive. So the receiving physician or non-physician provider, you're really giving us a jump on getting this patient evaluated and stabilized. So also look for other serious signs. Tearing pain radiating to the back. That with the crew that I work with here, I'd probably get a phone call on that. And the reason why I'd want that is because then I can have the CT scanner warming up because that's a surgical disease. And the minute you can diagnose AAA, you're going to put a bird in the air and get them to where they can have a surgical intervention. They got coughing up or vomiting up blood or coffee ground material. That once again is a pretty significant upper GI bleed. Think black tarry stools, think lower GI bleed, and then also make sure you've evaluated for signs and symptoms of shock. Remember, always goes back to the ABCs. Make sure the airway's good, place oxygen on, and always that left lateral recumbent position is always the go-to for somebody that you're questioning if they can handle their secretions or if they can handle vomitus and that sort of thing. And always, that's one thing with the COVID and now multiplicity of multi-drug resistant bacteria. Folks, you got to keep yourself safe, no matter if it's COVID or vancomycin resistant enterococci. You got to take standard precautions. You got to clean and disinfect equipment, wear gloves, face mask good, and never can wipe down with enough Lysol. Good stuff. And a few things to remember. Um, those abdominal organs do a lot of important functions for the body: pancreas, insulin, GI tract for digestion, etc. Remember, we divide it into four quadrants: midline and umbilicus. And if you can get some history, if it's a stretch pain versus a tearing pain versus a focal pain, that really helps the clinician um, have a better, more focused evaluation in the ED. Remember, assessment management, number one. Go ahead. Remember to not focus just on the abdominal pain, but make sure they're not hypoxic. Get them placed in a secure position and a transport to an appropriate facility. So, what is emergency care for a patient experiencing abdominal pain or distress? From the field, it would be some oxygen if you've got capabilities for IVs, starting some low LR or half normal, whatever you got, just to keep the line open is a real go. Try to determine which and all quadrants are being affected. So it's something to think about. Got abdominal pain, describes the pain is on and off over the past several days, becoming severe in the last hour. Go to the next slide. What additional questions would you like to ask the patient? Well, first of all, where's it at? Where does it go? What makes it better? What makes it worse? And is it positional? That will start determining if it's more vascular, more organ, more hollow viscous, or solid organ. So I'll open this up to questions, even non-abdominal emergency questions.
I want to ask about the COVID variants and whether signs and symptoms that you're seeing are any different than standard COVID that we've been seeing for the last year.
Yeah, that's a really good question. Now, one of the things about the UK variant, it seems to be much more highly contagious, and for those folks that have not been vaccinated, seems to be a more severe illness. So, other than severity of illness, it seems to be following the same pathway, which is I've seen people with COVID that I worked up for gallbladder disease, and then I tested them for COVID. They never had a headache, they never had a sore throat. They had diffuse abdominal pain made worse by eating. And then while the test was coming back, because we had a rapid test machine here pretty early on, then they developed the sore throat, the cough, and the headache. So with these new variants, I don't think we're going to see a lot of different presentations because the number one presentation with COVID is no presentation, especially for the young and healthy. For the older population, the shortness of breath, cough, loss of smell. Um, from what I've been reading and my colleagues in New York State that are dealing with it, they say it's basically COVID is COVID. It's just a different variant. And fortunately, it looks like our vaccinations have a pretty good protection against at least hospitalization and ICU placement. The same, I think, can be said about the South African variant and the Brazilian variant. No data out there that says that our vaccine is the efficacy is significantly lower, but I will reach in my crystal ball. We've often said here in Redfield that this virus is going to teach us more than what we know right now. Um, I would not be surprised that we see a kind of a booster vaccine coming through in late summer, early fall for these variants. And then what may happen with COVID, it may go from being a pandemic to being more like influenza, where it's just endemic. And then every year you get a vaccine. Remember, the COVID virus is the coronavirus, which the common cold is a member of the same family. These things change uh, their genetic sequencing and their um, morbidity. More, it just really is a moving picture. Good question.
Thank you.
Now, if you didn't read through the lines, I just said keep wearing your mask, wash your hands, do what Mama taught us. If you're cold, if you're sick, stay at home. If you got a cough, cover it with a hanky. I mean, some common sense stuff. Any other questions out there that I can take a shot at? You can play Stump the Chump. Well, Michaela, did I get done what I needed to get done?
Yes, sir. Yep. Perfect. And yeah, if you have any questions, feel free to put them in the chat as well too, and then we can have that. So, okay, so it looks like we did get a question in the chat that said, "What is the most challenging slash interesting abdominal case you have dealt with?"
Is that for me?
Yes. Yep.
Actually, probably the oddest one I ever worked up, and it was a total zebra, was one of my staff physicians when I was a resident had acute intermittent porphyria, which randomly he'd get excruciating abdominal pain, and it's so rare. Uh, but that was the most interesting workup. We finally solved it by getting a urine test, which is just crazy. This guy had been scanned so much that he glowed at night. And then there is a question about on there about what's the chances of surviving a AAA. Well, back in the day, the old data would say if you tore that last wall on in your ori under and the surgeon was opening, you'd have about a 50% odds after that aorta. Because remember, the aorta is about that big, and it will pump out all of your blood in just a matter of minutes. So if you have a aneurysm that dissects, odds, I suppose it could top an odd. I've never seen one. Most of those folks that I've seen that have had that have not survived, basically had this severe onset of pain. Wife or husband says, yeah, they've been having it off and on. Now it's bad enough to come in. And then I assume right when they become unconscious that it's called the intima or the inside lining of the aorta is now torn and they're just pumping blood into the abdomen. And there's not much you can do for it unless you're a surgeon. And even then, it's very difficult.
Great question. And it looks like I had a question come over here that says, "Is the abdominal aortic pain Can it be similar to pancreatic pain?
Oh yeah, yeah. Until you image or get lab back, that's a very difficult because they mimic each other, and you can even have some people that have kind of a chronic elevation in their pancreas enzymes and get kind of heading down the wrong path thinking it's pancreatitis, and then you image them and you see this large aneurysm that has not torn yet, and that's called an oculohopter reflex. That's when you see that on a CT, you just call for the helicopter because they're going to need to see a vascular surgeon. Very good question. Absolutely.
Well, I think with that, if there's no other questions, I think we'll call it and we'll end this. So thank you very much, Dr. Owens, for coming. We appreciate it. And you did a great job.
You folks hang in there. We're not done with COVID yet, but with that vaccine and some pretty good treatment. We just went through today with med staff here. The Bam Bam or the Bam Libafab is now being put in with its Estimavab and the for the outpatient treatment of COVID. And this thing, we're having more and more tools, better and better ways of dealing with this. And we're going to get through this. We just got to all stick together.
We will close this out. So thank you, Dr. Owens, once again. And it looks like we're getting thank yous in the chats. So, yeah.